What I wanted to talk about today was exercise and exercise utilizing it for concussion recovery. Exercise has become a staple, like a staple across the board in all of medicine. It's been, I wouldn't even say it's become a staple, but it should become a staple. It's across the board in standards of care for cardiovascular disease, renal disease, things like that. We use it for basically the foundation. And the reason being is that it has cardiovascular effects, it has immune effects, it has, hey, good morning, Shankar. It has immune effects, it has all sorts of great effects. And if you could compile all the research that we have for exercise and you could find a single drug that could do all those things, it'd be impossible. I said in a recent article that like while you go try to find the drug that can do all that exercise does, if I held my breath, I would die. Exercise in post-concussion, it was originally studied in post-concussion because we were trying to figure out all these people who have concussion, how do we get them better? Like, why aren't these people getting better? And so the research on exercise was originally for post-concussion syndrome, which is now being called persistent post-concussion symptoms. And then researchers are like, well, it's pretty safe. Hey, hello, I'm waving back at people. It's pretty safe. It's pretty effective. What if we started trying it more in acute patients? And so we're seeing it in pediatric populations. We're seeing it in just kind of more and more research coming out that like, hey, doing this acute after concussion is really helpful. And when I say acute, most of the research is looking at that like kind of 1 to 2 week mark, 7 to 10 days. But it's trending towards like maybe we could do this day 3 to 5 or day 1. So I'll talk about that. Basically, what we see in concussion, I've got some of my notes here, so that's where I keep looking. What we see in concussion is that you take the hit. I've talked a lot about this, but you take the hit, and part of that is often a rotational component, right? And that rotational component gets your brainstem, and we've got imaging studies that show the brainstem's disrupted, and that's where a lot of your autonomics, that's where a lot of your sympathetic, your parasympathetic, your heart control exists. And what we see is that for some reason, concussion patients, when we do exercise, we don't breathe as much after concussion. We hypoventilate, so we don't breathe enough. And so CO2 kind of builds up in the arteries and the blood. And CO2 is this potent thing that says, hey, when there's too much CO2, we should breathe more. We got to pump more blood. We got to deliver more oxygen, less CO2. And so the brain hyperperfuses, and we get headaches, and we get dizziness, and we get vision symptoms, right? And we feel kind of crappy. And it's because we're not breathing enough, and we don't have the normal regulatory control of blood flow to the brain. It should be tightly regulated. And one of the things that we can do is we can actually just find your threshold for exercise that's specific to you so that we can regulate those mechanisms. One of the cool things about exercise is that some of the cool things that help it work is that it increases your parasympathetic tone. So parasympathetic nervous system, rest, digest, recover. It's that it increases parasympathetic tone. I'm talking specifically about cardiovascular exercise. Increasing parasympathetic tone. After a time of consistent work, it increases brain-derived neurotrophic factor, so BDNF. That's kind of a popular term now, BDNF. But it increases BDNF. It improves your CO2 sensitivity, regulates cerebral blood flow, which ultimately decreases your symptoms. It helps you with recovery. So people with CO2 in their blood would get dizzy wearing a mask. All right, so I'm not sure if this is a clickbait kind of question. So I actually did a recent article on this. So go to my blog, drheisig.com/blog. The most recent blog that I did was on this second wave in COVID. We have zero evidence that masks do anything to your arterial blood gases. We've actually thrown masks on people, surgical mask, cloth mask, and no mask. And we've done cycle ergometer tests where we said, hey, we're just going to keep going up in the resistance until you can't go anymore. And there's no change in peak power. There's no change in performance. There's no change in arterial blood gas. There's virtually no difference between not wearing a mask and wearing a mask. So people who are like, oh, it's collecting CO2 or oh, it's decreasing my ability to breathe, we don't have the evidence for it. So that's kind of where that stands. What I'm talking about in concussion is that your brainstem is actually rotated and disrupted so that the sensitivity mechanisms are off, and that's why you have relative to your reflexive breathing. That's kind of what's going on in concussion, is you reflexively are not breathing enough relative to the work of your muscles. And so CO2 from the muscles, not from your ventilation, builds up. And that triggers the brain to say, oh, we should perfuse a little bit more, we should dilate. Thank you for doing those mask tests. I didn't personally do them. That was smarter researchers than me. You can see the graphs and the takeaways from the study in my blog. But we've done it on people resting, walking, surgeons, athletes, young people, healthy people, whatever. We've put it through. The one thing I will say is the notable condition for masks being kind of like a concern would be moderate to severe asthma, or like end stage renal disease where you're like on dialysis. Like that's kind of the two conditions that the research has pointed at. All right, so bringing it back on track. So exercise is a staple, should be a staple in medicine, across medicine. We originally studied it in post-concussion. It was safe and effective. And we're like, maybe we could do it in acute concussion. It's getting more safe and effective. It works by increasing parasympathetic tone, by increasing BDNF for neuroplasticity and recovery. It increases CO2 sensitivity, normalizes cerebral blood flow, which is why we feel better, why we're physiologically recovered. And this is also a reason that rest is actually one of the most, it's kind of falling out of favor. It's kind of a garbage recommendation, especially if you're an athlete, especially if you're previously an active, fit individual. Rest deconditions all of those things. So when you're resting, you're not exercising, right? When you're exercising, you're improving parasympathetic tone, you're improving CO2 sensitivity, you're improving all the things we just talked about. When you rest, those things are deconditioning. And so that deconditioning leads to these problems kind of being compounded. So prolonged rest, especially in fit individuals, especially in athletes, especially in folks who are active, is detrimental to recovery because we undo all the good things that exercise does. One thing we know that I'll point out is athletes and or fit folks in general, respond better to exercise, especially after concussion. So if you are a non-athlete, kind of sedentary couch potato, you get a concussion, exercise is going to work. It's going to take longer to work, longer to have effects than if you're an active, fit individual who has a previous history of better parasympathetic tone, better activity. Some of the research actually looks at some of the BDNF benefits, and some of the benefits of exercise come when it's voluntary exercise. And we know that athletes and active individuals don't like that they're told not to go bike or told not to go play their sport. So they want to exercise, and some of that voluntary effort might actually play a role in why the benefit occurs. Is the chart in the background for eye reacting stuff? Yeah, it is for cervical visual vestibular rehab. We can talk about that some other time. I'll actually bring that in at the end. So we need to think about exercise not so much as like a thing to do, but as a medication that can be dosed, right? So it has these beautiful physiologic effects. It has these beautiful clinical effects that act much like a medicine. We're decreasing symptoms. We're improving outcomes. We're promoting recovery with exercise. So it needs to be thought of as a medication that you dose. And just like any medication, you need the appropriate dose. So how do we find the appropriate dose of this medicine, of exercise? In office, we will use the Buffalo Concussion Treadmill Test or the Buffalo Concussion Bike Test. And basically what that looks like, people hear treadmill test or bike test and it sounds scary or intimidating or hard. But what it is we put you on a treadmill at somewhere between 3.2 or 3.6 miles per hour, depending on how tall you are. And we'll basically have you walk at that kind of casual speed, 3.2 to 3.6 miles per hour, at 0%. And then after a minute, we go 1%, 2%, 3%, 4%, 5%. We go up to 15% incline as we're monitoring heart rate, as we're monitoring symptoms, as we're monitoring your perceived exertion, like how hard does this feel? And that basically as we go up, if you don't have the physiologic autonomic regulation, all the things we just talked about will happen. You'll have this like hyperperfusion, this CO2 intolerance, and symptoms will flare. And the point at which symptoms flare, we track that heart rate and we go right there. We are not going above that point. We're not going above that heart rate. And so say your heart rate was at like 140, we'll take like 10 to 20% off that heart rate. So we'll give you 80 to 90% of that heart rate. And we'll say, hey, I want you to do this every day for 20 minutes. So 6 to 7 days a week, 20 minutes of a steady state cardio that is below that symptom threshold, as long as your symptoms don't flare during your workout sessions, but 20 minutes every day below that symptom threshold. And then you can either retest or you can simply add 5 to 10 beats per week, right? So I don't have the math on me right now, but if you were at, like, say symptoms flared at around 140, most concussion folks can't get past 50 to 70% of their estimated maximum heart rate without a symptom flare. So for folks, that'd be right around 140, right around 130, 140. So that would put your 80 to 90% right around 120, right? 116, 115, 120. You'd be exercising steady state on a treadmill, on a bike, on a rower, on an elliptical. Maybe not a rower if there's like a vestibular component, but you would go at that steady state for 20 minutes every day. And I want to emphasize the every day, and I want to emphasize for post-concussion patients. In acute concussion, we'll see benefits in 10 days. We'll see sleep in young adolescent males. We'll see sleep and mood and physical and cognitive symptoms drop in 10 days. In post-concussion, that might take 4, 8, 12. I've seen the research go up to 16 weeks. It's a daily thing. Exercise is a daily thing. Does that threshold vary a lot person to person? Yeah, 100%. I'm actually going to talk about a fancier, kind of newer thing. There's only one study I've seen on it where we actually use a stethoscope to measure carotid bruit, or carotid murmur. That I'll talk about that in a second, but the thing varies quite a bit. So basically, like depending on your threshold, depending on whatever, when your symptoms flare, we're going to target that heart rate, and that's going to be different for everyone, but it tends to be in a range. We tend to see that 50 to 70% of estimated max heart rate is where intolerance to exercise sets in for a lot of people. I'm actually going to talk about that murmur right now. So in my flow of notes. So the fancier thing for folks, if we want to do this, I see it being useful really acutely, or for folks who have been struggling for a while. Because one of the things we see in research, sometimes you get in the athlete realm, when you get folks who are on the cusp of college or on the cusp of pro, it's called sandbagging. So they'll sandbag, they'll purposely do less than their best on baseline tests, on symptom reports, on whatever, because if they get a concussion, they know that they only have to beat this less than their best baseline, and so they can return to play faster. So symptom reporting and subjective reports they're not always reliable for an accurate physiologic recovery. Question here: are there individuals when the protocol does not produce results? Yes, I'll talk about that after I talk about this murmur. So when this thing goes on. What if 20 minutes is too much? Drop down to 15 or 10 or lower heart rate? I'll be talking about, these are awesome questions. I'm actually talking about all that in a second. So basically, symptom reports aren't always all that reliable because sometimes you got these folks who are like, I just want to get back. Like, screw you, doc. I just want to play, or I just want to exercise, or I need to get back to work. I don't have symptoms. And their head is pounding or whatever. Still cross, right? Nice. Good job, William. Crisscrossing America on his bicycle. So one of the things we can do that's a little bit more objective, doesn't have as much research, but is pretty cool is, so if you feel kind of the angle of your jaw right as your neck starts, that's that carotid pulse. That's your carotid artery. That's that pulse. One of the things we know is that a normal response to exercise is a massive increase in blood flow. Your cardiac output goes up, and your brain is like, whoa, we don't want all that blood flow. We want the blood flow to be steady. We want it to be normal. We don't want this massive flux and inflow of blood. So your internal carotid arteries will kind of squeeze a little bit to kind of regulate that pressure. Think about a garden hose, just kind of saying, like if you turn the hose up, but you want the same flow here. You kind of constrict it and impede some of that flow so that blood in the brain is normal. What we found is that in young, healthy athletes, the point at which we'll hear that happening is around 150 beats per minute. In concussion, folks, we hear that happening at about 120 beats per minute. So one of the ways, that's just kind of an average sample of college athletes. That's not the general population. That hasn't been reproduced a ton of times. It's kind of hard to hear, but it's a cool objective measure to go, hey, measure on someone's neck while they're on a bicycle. We basically just try to ramp you up as close to 150 as we can without symptom flares. And the point at which we'll hear it, it almost sounds, if you've ever taken a blood pressure, have you ever heard a blood pressure pulse? It kind of sounds like that. So you have to listen over their breathing, but you'll hear this whoosh, whoosh, and it might happen at 115, 120, 125, but that's that heart rate. So you might not even experience symptoms yet. You might not experience symptoms until 140, but your autonomic regulation said whoosh at around 120, 115, and so that would actually be your threshold. So I'm excited to see more research come out on that. But back to the question, so what if 20 minutes is too much? Are there individuals where the protocol doesn't produce results? So what the goal is to try to get to, you can produce 20 minutes of consistent exercise for several days, right? So Monday, Tuesday, Wednesday, Thursday, you can do 20 minutes of exercise at 80% of your estimated heart rate max or higher without a symptom flare. And if you can do that without a symptom flare, you are considered physiologically recovered. And I'll talk about that more in a second, because there's physiologically like autonomic recovery, and then there's like vestibular, cervical, other recovery. So you could pass this test. So say this protocol doesn't produce results. Say you get all the way up to 15%. After you get to 15%, we'll start increasing the speed. And if you get through that whole test and you reach maximum perceived exertion, you're like, doc, I can't work any harder, or you've hit your max of your estimated heart rate, you've passed. You've passed. Your symptoms are likely not due to blood flow issues. They're likely not an autonomic dysregulation. It's likely a vestibular, an ocular, a metabolic, hormonal, some other issue. So you can, if the protocol doesn't produce results, that's a good thing. That's a pass. Like, you did good. That means that is probably not a component of your particular concussion picture. Now, on the flip side of that, what if we get to your threshold, right? We say you got symptoms at 140, we're going to have you exercise at 115, 120, or you had a Turk murmur at 120, we're going to have you exercise at 110. What if 20 minutes is too much? Basically, what we're looking for is symptom-limited activity. So I've talked about this before, but on a scale from 0 to 10, if 0 is no symptoms at all, and 10 is like, pardon my language, but 10 is like, fuck me, like this is terrible, you don't want to flare more than 2 points. So your overall symptom picture when you start the exercise, you're in concussion recovery, you're not feeling the best, your overall symptom picture when you start exercise is like a 5. You're like, I'm not the worst, but I'm definitely not the best. I'm kind of right in this middle of like, I don't feel so great. If you flare to a 6, that's okay. If you flare to a 7, start to think about it. But if you flare to an 8, you're stopping the exercise. So that could occur at 10 minutes, that could occur at 15 minutes. But basically you're stopping the exercise, you're pulling back. And then the next day you're going to try it again. Talk with your doctor though, because they might just pick a different threshold for you. So that's kind of if that 20 minutes is too much. There's also some research that says you don't necessarily need to go more than like 45 minutes. 20 to 30 minutes is kind of a good sweet spot. Questions. So are you in Bellevue, Washington? No, I am not. I am licensed in Washington, so I do do telehealth for concussion patients in Washington State. I used to live in Seattle, kind of the like Northgate, Green Lake area. Currently I'm in Scottsdale, Arizona right now. This is where I'm seeing people physically. So next question, what if you can't walk 100 meters really slowly without a symptom flare-up? That will be a conversation for probably 2 weeks from now, because you're looking at a significant dysautonomia at that point, probably. So maybe something like POTS, postural orthostatic tachycardic syndrome. I would be looking for you at tilt table tests, at probably for a Turk murmur for you, just to kind of see what is that threshold. Do you have a normal response to gravity? We might have to start with, basically with POTS, we'll start with like recumbent protocols. I'm going to fall out of my stool, but those bikes where you're kind of leaning back, you're not completely upright. We'll start with recumbent protocols, kind of not fighting gravity too much. You're kind of back. We'll build up that cardio parasympathetic tone, build that cerebral blood flow regulation. Then we'll get you on a stationary bike. Then we'll get you to other stuff. But if you can't walk even like a football field or a track length without a symptom flare up, I would think more on like a more significant dysautonomia, something like POTS, where we would have to do a little bit more testing to see what your reflexes against gravity are, let alone your reflexes to exercise. Cool. Yeah. So basically, the whole goal is to work to be able to do 80% or more of your max heart rate, because at that point you're physiologically cleared. And so again, I wanted to say that can take 4 to 16 weeks. That's 1 to 4 months. And the results are often better if you're previously active, if you're previously fit. So this is where I'm a huge advocate for cardiovascular exercise. I've got a 4-part series on my blog. If you just type in like cardiovascular into the search, there's part 1, 2, 3, and 4, where I break down like what is cardiovascular training, true cardiovascular training, how do you do it, why it's important, all that great stuff. But cardiovascular training is massively important, and it's really important for even pre-concussion. Just having good cardiovascular fitness before a concussion can make your recovery better. It's awesome. You want to lift more weights, you want to be more powerful, have a good aerobic base, because that's the build for anaerobic, that's the build for power, that's the build for all of it. So I'm a huge proponent of that. But the post-concussion journey can take 1 month to 4 months to longer. We don't see BDNF changes until around 5 to 6 weeks. So again, that neuroplastic change, you'll get a dopamine hit right away. That feels really good. There's some plasticity there, but the BDNF levels don't typically rise until 5 to 6 weeks. So it's something you got to be consistent with. Once you get that threshold, you're working almost every day of the week for 20 minutes, walking around the block, using a heart rate monitor so you're accurate, and trying not to do so much that your symptoms flare, but just consistency, 6 to 7 days a week. Add 5 to 10 beats onto your threshold each week, so long as your symptoms aren't flaring, and really just working towards 80% or more of your estimated max heart rate, because that's when you're going to be physiologically recovered. What if exercising at a low threshold still produces inappropriate emotional response, almost panic attack response? Is it better to drop down more? What if the person does have POTS or vestibular issues? Okay, cool. So that's what I was kind of mentioning before. So if that threshold still spikes symptoms, we're going to try to figure out how to drop the threshold. How do you figure out what's driving that? So that's a part of like the full workup. So I guess I'll talk about the next point is exercise helps us diagnose and rule out, right? So when you look at concussion, there's 5 different reasons you might have post-concussion syndrome. There's 5 different types of concussion. There's mood, mood anxiety, cognitive fatigue, migraine, ocular, vestibular. So there's 5 different types of concussion. You can profile that through a clinical concussion profile screen, a Rivermead post-concussion questionnaire. But you're looking at these types of concussion, and then there's reasons why they might have it. Autonomic issue, which is what we're talking about today. If there's an autonomic issue, you're looking at blood flow, exercise regulation, visual vestibular problems, cervical problems, metabolic hormonal problems, or psychological components. So PTSD is a huge thing in the concussion world. But exercise helps you rule that out, right? So if you're doing a bicycle test or you're doing a treadmill test and they cannot pass it, there's an autonomic component. Now, is it purely treatable by exercise in the functional neurology world? There's some other stuff you can do to help autonomics that aren't just exercise. But basically helps you diagnose and rule it out. So if someone comes into you with a bunch of emotional symptoms or a bunch of balance issues or vision issues, and you get them on the bike and they cannot pass the bike test, you have to make sure you're not going to get these other issues 100% unless you can also help out with blood flow. So that's why exercise is kind of the staple. If you can get them on the bike, they have emotional complaints, they've got vestibular complaints, they've got visual complaints, and you can get them on the bike and they can pass the bike test, you know that autonomic component is likely not as big of a deal in their whole vestibular, emotional, visual picture, and that is going to lead you down a rabbit hole of doing visual vestibular training, cervical training, getting a proper referral to a counselor, a therapist, psychologist, that sort of thing. So it helps you kind of rule it out. It like shakes the dust off, so to speak, because your brain requires food, it requires oxygen, it requires stimulation. And if it doesn't have fuel or oxygen, the stimulation doesn't matter. The visual vestibular rehab doesn't matter if I'm not getting accurate, adequate blood flow and oxygen. Does that make sense? So when do beta blockers and other medications? That's more getting into POTS. So we can talk actually a lot more about this in a couple weeks. I think next week I'm talking cervical, like headache stuff, and then the week after I'm going to talk dysautonomia, postural orthostatic tachycardic syndrome. Because when you're getting into beta blockers and what if they can't pass the test and all this stuff, you're getting more into the dysautonomia, and that occurs in a subset. Like I believe it's like 30% of people with POTS. I'm pulling this number out of my butt, but I believe I read the other day that it's like 30% of people with POTS had a previous concussion within 3 months or something like that. So we're getting more into the dysautonomia, and in the interest of time, I want to start wrapping this up. But basically, the exercises, kind of the baseline. Are we getting blood to the brain? If we're not getting blood to the brain, other stuff's not going to be as helpful. Does this help with those who had TBI many years ago? Yeah, 100%. Exercise was originally studied for post-concussion, and when that was successful, we started using it in acute concussion. So exercise is super helpful for folks with post-concussion. All right, so wrapping it up from home, because I know lockdowns are hitting. We haven't had one here yet in Arizona. Who knows what we'll do as a state? When you look at our numbers per 100,000 people, we're off the charts compared to Washington, Texas. That's what I've looked at so far. But yeah, so per capita, we're not doing so great here in Arizona, but Chicago lockdown, Oregon lockdown, I believe the whole West Coast is doing a lockdown. So from home, what can you do? Remembering that a Turk murmur happens in concussion patients at around 120 beats per minute, you can use that as your threshold. So you can say, I'm not going to go above 120 beats per minute, and I'm just going to go. And if symptoms don't flare for a week, next week I'm going to go to 125. Next week I'm going to go to 130. Next week I'm going to go to 135, right? So basically 20 minutes every day at a sub-symptom threshold. So don't let symptoms flare more than 2 points. And if you don't have a means of tracking heart rate, or you don't want to risk tracking heart rate, one thing that Dr. Nathan Kaiser had recommended was most people have like their phone or their watch will track steps. So look at your average step count for the last week, and just try to add 100 steps to that every day, every couple days, every 3 days. So you're not so worried about heart rate, you're not so worried about metrics and data. You're just like, hey, can I get more steps today than I did yesterday or the day before, as long as my symptoms aren't flaring? Getting outdoors, weather permitting, getting outdoors, so long as it's not icy, you're not dealing with vestibular issues, you're not going to fall and hit your head again. As long as you're not at risk of hitting your head, getting outdoors, getting exercise, awesome for recovery. Thank you guys for joining. I appreciate the kind words. Foot drop causing shaking in back of head, headache flares. That's a bigger issue. That's a foot drop causing shaking of the back of the head, headache flares. That's a different issue. That's something I would actually have to examine you for and talk about. So thank you. I'm going to make one last note here for those of you sticking around, because that's a great question. Strength training, add strength training in, or only focus on cardio activity every day. We don't add typically strength training until you can pass that 80% threshold, because strength training does all kinds of things to blood pressure and all kinds of things to your cardio regulation that you want to have a baseline before you jump into. So when we're looking at athletes for return to play, we'll do like this treadmill test for, like, let's say I got a hockey player coming in here. Later today with acute concussion. Throw him on the treadmill, find his threshold. He's going to work at that for 1-2 weeks probably, and in about 2 weeks, in the average like fit, like athletic individual, in about 2 weeks, they'll probably pass that Buffalo concussion treadmill test, and then I can move them into pretty basic resistance training, getting a little more sport specific with intervals. Once they can go a few days with that, then we're moving into like they can get on ice. He can get back on the ice with practice. He or she can get back on the ice with practice. And after that, we'll put them through a more aggressive protocol. There was another question. So strength training comes in after they can pass this concussion test when working on the threshold. 20 minutes of training, 100%. Cool. So I'll try to recap just the highlights in the caption, and I'll just post this one because this one had a lot of interaction. Ashley, yes, I can just share this one right away. Cool. So recap: exercise is awesome. Try to, if you can, get with a doc who can perform an exercise test. You're keeping it below symptom threshold. You're doing that as often as you can, 20 minutes, 6-7 days a week. If you're in the post-concussion bucket, this can take months, but please don't give up. The results are there. The results are awesome. So it can help us rule out other issues too. If you can start exercising fine, but you're still dizzy or you're still dealing with headaches or other stuff, it's probably not an autonomic issue at this point. It's probably a visual or a cervical or vestibular issue that then we can tease out, and we can comfortably tease out because we know your exercise is fine. So that is that. If you can't get a test, start with a threshold less than 120 beats per minute or at 120 beats per minute. Add 5 to 10 beats per week as long as your symptoms aren't flaring, or you can just add 100 steps to your average step count every day, every couple of days, as long as symptoms aren't flaring. Thank you guys. I appreciate the engagement. If you have any questions, you want to hear any particular other talks,